students, this is the first meeting for our new office bearers, and welcome you all for this TAMS CME program for postgraduates. Today we have one case presentation by MMC Madras Medical College PGs, and the examiners will be Professor Dr. Srisaravanan, Madurai Medical College, and Professor Dr. Raghavendran, Director, and Professor Madras Medical College. Kindly take over, Dr. Sri and Dr. Raghavendran.
Naveen, are you ready to present the case?
Yeah, sir. Sir, shall I start, sir?
Yeah. You just present the case.
Satish. Good evening, sir. Today, long case presentation. Today, I want to thank my director, Dr. Raghavendran sir, for giving this opportunity to present the case, and thanks. Straight away, I start the case. My patient, Mrs. S, 39 years old female, daily laborer by occupation, studied up to 6th standard. Informant is patient and her husband. Reliability is good. Patient is ailing from Chennai, place called Retteri. She came with chief complaints of hearing loss in the right ear for past 1 year, then ringing sound in the right ear for past 1 year, and unsteadiness in walking and swaying towards the right side for past 6 months. Headache for past 5 months, and decreased right-sided facial sensation for past 2 months.
Yeah.
History of presenting illness. Patient was apparently normal till 1 year back when she noticed difficulty in hearing over the phone in the right ear. It was insidious in onset and gradually progressive. It was forcing her to hold the mobile on the left side. She was able to hear the sound, but she had difficulty in understanding the speech. She used to turn her head towards the right to listen the voice while talking to her family members. Now for past 3 months, she is not able to hear any sound in the right ear.
Yeah.
She never had abnormal increase in the perception of loudness or sound with increase in the sound volume while watching TV or hearing music. There was no history of improvement of sound in the noisy surrounding, no history of earache, ear discharge, or trauma to ear. There was a history of insidious onset of ringing sound in the right ear, which the patient noticed at the same time when she started noticing the hard of hearing in the right ear. It was continuous, non-pulsatile, high-pitched in nature, hearing without any external auditory stimuli, not heard by patient's relatives. It was not disturbing her sleep or daily activities. The ringing sound stopped for past 3 months. Later, she developed insidious onset of unsteadiness while walking in the form of swaying for the past 6 months, and the history of tendency to fall more on the right side with the progression in severity. Now it progressed to the level where she stand and walk only with the support of her family members or nearby wall or things for maintaining the balance for past 3 weeks. She is able to sit up from lying down position without swaying. History of vertigo was present on and off, associated during walking in the form of spinning movement of environment and surrounding things, which was moderate intensity with nausea and no vomiting. It was relieved on lying position. There was no history of head nodding or involuntary movement, no history of jerking while taking any object in the fingers, no history of significant worsening of symptoms in the dark, no history of unsteadiness while washing face or feeling of walking on cotton wool, no history of weakness of limbs or neck movement, no history of buckling of limbs, stiffness of limbs, no history of thinning or wasting of limbs, no history of vomiting. Patient has history of headache for past 5 months, which was gradual in onset, localized to bilateral forehead in the frontal region, compressing type, progressive in nature, more during the daytime. It was last for 15 to 20 minutes, aggravated more on doing any stressful or painful work, which was relieved by medication. No history of projectile vomiting or transient visual obscuration. History of decreased entire right-sided facial sensation for the past 2 months, which was insidious in onset, gradually worsened, initially noticed while washing face and bathing in the form of reduced touch and hot cold sensation. A history of reduced cloth and insect bite sensation, also on the right half of the face when compared to the left. She was able to chew food normally, no history of difficulty in any jaw movement. Patient gives history of decreased taste perception, which was insidious onset. Noticed initially during tasting food for salt while cooking since 2 months. Later, she gives history of difference in the taste perception on right half of tongue compared to the left for sweet, sour while mixing food in the mouth. There was no history of facial asymmetry. She was able to close both the eyelids without any difficulty. No history of drooling of saliva or deviation of angle of mouth to one side. No history of decreased lacrimation or salivation. No history of altered sensorium or seizures. No history of neck pain. No history of lack of sweating, drooping of eyelids. No history of bowel bladder disturbances. No history of any trauma. No history of significant loss of weight or appetite. There was no history of decrease in smell sensation. No history of difficulty in recognizing colors or eye pain. No history of redness of eyes, watering of eyes, flashing of light. Able to open both the eyes normally. No history, no restriction of any eyeball movement. No history of hoarseness of voice or regurgitation of food. Able to swallow. There was no hoarseness of voice. No speech difficulty. No history of difficulty in shrugging shoulder or turning head side to side. Able to chew food in the mouth. No difficulty in protruding her tongue out. Past history. Patient is not a known hypertensive, diabetic, bronchial asthma, heart disease. No similar history in the past. No significant family history. Patient consumes mixed diet, has good appetite. Her menstrual cycle was normal. She was married and has 2 children.
Now you are going to summarize the symptom analysis, sir.
Yes.
First is summarize the history.
39 years old female patient came with chronic progressive neurological illness in the form of hearing loss in the right ear for past 1 year and tinnitus in the right ear for past 1 year. Then developed unsteadiness in walking, such as swaying towards the right side for past 6 months, and headache for past 5 months, and decreased right-sided facial sensation for 2 months.
We will go one by one. First, you said loss of hearing loss. No, what do you think of? What do you think of the hearing loss? What do you think about the hearing loss?
It is a sensory neural type of hearing loss,
or conductive deafness, or something.
Sensory neural type of hearing loss.
Why are you saying that it is a sensory neural deficit? What are the history suggestive of sensory neural hearing loss? What is the difference between the conductive difference?
In conductive hearing loss, patient will be having ear discharge, ear pain. Okay. Yes, sir. This patient will be having ear discharge or ear pain can be there, sir.
Okay. Sensory neural hearing loss. What are all the symptoms pertaining to the sensory neural hearing loss in this patient?
Here, patient is able to hear the sound, but not able to appreciate the speech. Here, speech discrimination is poor, sir.
Why are you saying like that?
How will you identify that? Sir?
How will you identify speech discrimination deficit? What are all the words you give? Ask the patient to tell. There are certain phrases of words you go to ask the patient.
Bisyllable words.
There are 2 qualities of speech. What is
pitch and
not the pitch. There are a lot of things in this speech. To quantify that, you have to give some monosyllable word or double syllable word like that. What are the things you will ask the patient? Speech discrimination.
Bisyllable words will be.
What will you the presentation? What is in this patient? What is present in this patient?
Here, patient is not able to understand the speech. He was repeatedly asking again and again what we are telling, or the attenders are speaking.
Okay. Then you said she's not able to understand the word in the crowd or something. There is an history, no? What is the importance of that?
In conductive hearing loss, patient will be able to hear better in the noisy surroundings.
Sensory hearing loss.
there will be no difference in the hearing in the noisy surroundings.
Why?
In conductive hearing loss,
In other words,
patient,
there are this is a simple question. You have to tell me the differentiation between the sensorial hearing loss and the conductive hearing. What are all the points favor of conductive sensory loss? What are the points in favor of sensorial hearing loss? That is the simplest way. You have to classify according to that. You have to tell the difference between these two.
in conductive hearing loss, patient will be able to hear better in the noisy surroundings.
Okay.
In sensory neuron hearing loss, in cochlear type of pathology, patient up to a particular level of sound not able to hear anything. Suddenly, after increasing sound, patient will have increased perception of sound.
What is present in this case?
That thing was not present in this case.
Then what do you think about that hearing loss? Is it a conductive one?
No, sir.
Okay. Then progress to other symptomatology. One is hearing loss. You think about it.
What is asking is be very clear. See, you said something about that cochlear deafness. That is called as what phenomenon?
Recruitment.
Recruitment phenomenon. Okay. You said, see, you were clear that it is only a sensory neural type of deafness. And you also mentioned that recruitment phenomenon is present or absent?
It's absent in this case.
It is absent. So that is what sir is asking. So what type of deafness is this? Is it?
Since this is not a conductive hearing loss, as per the history, not and patient is not having a recruitment phenomenon.
Recruitment phenomenon is absent. So what will
be the pathology?
This will be a retrocochlear type of sensory neural.
That is
That's what we are asking.
Okay. Fine. Proceed.
Patient is having ringing sound in the right ear for past 1 year. Patient is having tinnitus in the right ear for past 1 year, and it stopped after patient was having loss of right ear sound perception. After hearing loss in the right ear, patient had a stoppage of stopped hearing tinnitus.
Something wrong with that, with my connection.
So what do you infer from this tinnitus?
Initially, when the lesion was small, patient was having tinnitus as the initial symptoms. After it increased in size and patient had a loss of right ear hearing, he stopped having tinnitus.
So complete loss of hearing has resulted
Hearing in the
in stoppage of the tinnitus. That's
tinnitus.
Okay. What are the features you will ask in case of patient complaining of tinnitus?
Nature of the tinnitus, whether it is a roaring type or pulsatile type, whether it was only subjective or told by relatives also, whether it was disturbing her daily activities, like during sleep, she was not able to sleep due to the tinnitus, or any aggravating or relieving factors.
So what type of tinnitus an examiner can hear?
Vascular tumor causing tinnitus.
Vascular tumor, like you mean glomus jugular like tumors? Yeah, that will cause pulsatile tinnitus.
Pulsatile tinnitus.
What type of tinnitus will the examiner also will be able to appreciate along with the patient? It's vascular only, but a different pathology. Where you can hear bruit.
Carotid body tumor.
Carotid stenosis or CCF. To proceed. So tinnitus has stopped. Along when there is a complete loss of the hearing.
Loss of
Okay. Then what is the next symptom?
unsteadiness while walking for past 6 months, sir. Patient is having swaying towards the right side for past 6 months, sir. Now she was able to walk only with the support of family members or only by holding things, nearby things, for maintaining balance for past 3 weeks. Swaying may be due to lesion in the CP angle or any lesion affecting the cerebellum.
See, you should first define whether swaying is possible and what are the symptoms of swaying is present in when there is involvement of cerebellum. Okay, one you said.
Cerebellum, vestibular, then posterior column.
Apparatus. Then
posterior column.
So analyze this symptom and say what is the possible pathology. I mean, what is the possible substrate that is involved leading to this unsteadiness?
The patient is having right-sided hearing loss, and here she is telling that she is having unsteadiness and swaying towards the right side. Probably can be a CP angle pathology with involvement of cerebellum or cerebellar peduncle compression.
Don't say CP angle directly. Okay, just tell structures. Correct? CP angle சொன்னா எப்படி அது? You have to show the structures. எப்படி CP angle எப்படி they say you see you already saw the case.
What are the structures?
Sri, take over.
What are the structures involved? Swaying up.
Right. You said it is possible in cerebellar involvement.
Cerebellar
involvement. Posterior column. How did you differentiate and find what is the possible substrate that is involved in this for this unsteadiness? Avladhan. Sri parunga.
Sir, unsteadiness while washing face will be present while closing eyes will be present in the posterior column involvement. Sir. Here the patient is not having unsteadiness while washing face. So it rules out posterior column involvement. Sir. Patient is having swaying towards the right side while walking. So probably it can be involvement of right side cerebellum causing cerebellar pathology causing swaying.
Okay.
Patient is not.
Is it any motor involvement or not?
No, sir. No history of any weakness.
No weakness.
No weakness.
Okay, go on to next symptom. Headache.
No.
You said some headache, no?
Yes. Sir.
What is that headache?
Headache was there for non-ICP type of headache. Sir.
Here is saying it's a non-ICP type.
It was not associated with projectile vomiting or any other.
You are which year PG? Final year PG or first year?
Final year PG.
For the first year PG, like what are the how will you differentiate between the IC type of headache and the non-ICP type? What are the characteristic features of ICP type of headache? For the sake of first year PGs, you have to tell all these things. There are a lot of PGs.
ICP type of headache will be more on the morning. More on the early morning after waking up from bed. The patient will be having projectile vomiting. There can be a transient visual obscuration can be present.
You have to tell the scientific reason behind it. What is the scientific basis behind each one of this? We early morning headache is the ICP.
During sleeping, venous return to the brain will be increased, sir. So it causes venous pooling and rise in the intracranial pressure. That leads to the early morning headache. Then during sleeping, there will be CO2 retention during the sleep time that causes vasodilatation. After patient vomits, the CO2 will be washed out. So then the ICP will decrease. Then transient visual obscuration during rise in the ICP, there can be thinking of posterior cerebral artery that can lead to transient visual obscuration.
Is it the cause or something else?
See, transient, I mean, posterior cerebral artery involvement is one that can cause transient visual obscurations. What are the other causes is what sir is asking.
Vision, what is the cause for transient visual obscuration?
Occipital.
That is
What
finished.
happened there? What happened there? Why ICP causes visual obscuration? Okay.
What happened? Is there any other vessel involved there? What happens to the optic nerve? What
Optic now, what happened to
What
Yes,
happens to the
that?
subarachnoid space?
Sir, due
Okay, go on,
to
read.
right ICP, retinal artery compression can be there.
There are lot
Sample
of
கொடுக்கலாம்.
there are lot of causes for the visual obscuration. These are two causes you tell. What are the other two causes of that for visual obscuration? Go on, read. Okay, next. What are the there are visual obscuration in headache and ICT type of headache. Why projectile vomiting is there?
Sir, projectile vomiting to wash out the retained carbon dioxide, patient vomits.
In ICP, or what happened to the what is the projectile? What is the nature of projectile vomiting?
What do you mean by projectile
vomiting?
Usually, for vomiting, patient will have nausea. Sir. Here, there will be no nausea associated with vomiting.
Okay, there is no nausea. What is the cause for this projectile vomiting in ICT of headache?
Vasoconstriction.
Not the vasoconstriction. What is the vomiting center? What is the vomiting center? In the floor of the fourth ventricle, there is a place called area postrema. By ICP increases the pressure over the area postrema that causes projectile vomiting. Okay.
Yes, sir.
What is the characteristic feature of area postrema?
Does it come into a group?
Without, it is not extra-arachnoid.
In extra-arachnoid. Not extra-arachnoid. What will you say that?
Professor gave the clue.
What is divide of that area? The organs present outside the
CSF.
See, they don't have a barrier, right?
Blood-brain barrier.
What are all the other organs present in the outside?
What are they called and what are the other organs?
Pituitary.
There are four to five organs there. What are all they?
Pituitary.
Area postrema, posterior pituitary.
Then
okay, go. To tell the characteristic features of ICT type of headache, there will be visual obscuration, projectile vomiting must be present, early morning type of headache must be present. All these things are present in this case or not?
No, sir, not present.
It is not there. So there is no ICP in this case.
Yes, sir.
Is it your conclusion or my conclusion?
No ICP, no increase in the ICP.
What it signifies? What is the signification of that?
The rules of hydrocephalus causing a
There may not be hydrocephalus. Okay. Proceed to the next symptom.
If you have decreased sensation in the right side of the face for past 2 months, initially noticed while washing face or bathing in the form of reduced touch and hot and cold sensations. There is a decrease in the entire all the sensations on the right side of the face, probably due to the involvement of trigeminal nerve.
Okay. Okay. Next symptom.
patient gives history of decreased taste perception on the tongue for past 2 months. Sir. He was noticing the difference in the taste perception on the right half of the tongue and compared to the left while mixing the food on mouth. Probably the involvement of the 7th cranial nerve.
How will you test taste?
Sir?
How will you test taste?
Examination.
We are in history only. Okay. You said there is a loss of taste sensation in the anterior aspect of the tongue. For which type of, for which taste is lost?
Initially he was telling while cooking, she was checking for the salt in the cooked food. Sir. She was telling that the sensation was decreased. She was telling, sir. But after asking, she was telling that while eating, she was able to feel the difference in the taste perception on the right half of the tongue. Sir.
Okay.
So,
Okay, proceed to next.
What are the how many different types of taste is there?
Sweet, salt, sour, and bitter.
And what is the fifth one? There are 5, right?
Yes, sir.
What is the fifth one? Okay, go and read.
Yes. Next symptom, pa. That's all.
That's all, sir.
Huh?
Yes.
No,
sir.
no weakness.
No weakness, sir.
No drooling of saliva, like that. Nothing is there.
No, sir.
No speech. No speech. No speech.
No difficulty.
Okay. Proceed. What do you ask in the past illness? What are the things you ask in the past illness? What are the things you have to ask in the family history?
Family history, any family members affected with similar history or
what do you
having any brain tumors operated for any brain tumor?
Okay. For brain tumors, you have to ask some genetic related neurofibromatosis 2 type of illness. No, they are run in families.
Yes.
So that type of history you have to ask in family history. Next.
Why brain tumor alone you say?
Spinal tumors also can.
It can be a spinal tumor also. Yes.
Now you summarize your history. You have to tell the positive. You have to summarize the history and you have to come to a provisional diagnosis with the possible causes for the illness.
See, what are the substrates involved? What is the possible localization? And what are the possible
pathological causes for the illness?
And give a provisional diagnosis.
Here, 13-year-old female came with chronic progressive neurological illness in the form of hearing loss in the right ear for past 1 year. Here, the substrate involved is the 8th nerve. And unsteadiness in walking, swaying toward and ringing sound in the right ear. It also signifies the substrate is in the vestibulocochlear nerve. And unsteadiness in walking or swaying towards the right side for past 6 months. Here the substrate involved is the right side cerebellum.
You summarize fully. You may not discuss all these things now. You have to in summarizing the history, you have to tell that this is a 15-year-old like that. This female come to the hospital with the possible involvement of this now cerebellum, right side, most probable like that. You have to tell.
13-year-old female came with chronic progressive neurological illness in the form of hearing loss in the right ear with ringing sound in the right ear and unsteadiness and walking swaying towards the right ear.
You need not tell all these things. You have to tell that
probably the substrate involved are 8th nerve and 5th nerve and the cerebellum, right side cerebellum.
What about the seventh cranial now?
And since patient is having a taste decreased taste perception, seventh nerve is also involved.
You want to tell that one, that also. Then
Yes. And
what about the
probable-
motor involvement? What about the cerebellar involvement?
patient is having a swaying towards the right side, sir. Hence, right side cerebellar involvement is also there, sir.
You will not keep on telling me.
Yes, sir.
No, you have to summarize everything in a single line. You have to tell everything in a single line. You will not put into the. We didn't need the possible causes for that. No? You have to tell possible involvement of this and this substrate. Up to this, you have to tell with or without hydrocephalus. You have to tell me that.
Yes.
Tell me in that form.
39 years old female came with chronic progressive neurological illness in the form of hearing loss in the right ear and unsteadiness in while walking and right side decreased facial sensation and taste sensation. Sir. Probably the substrates involved are eighth nerve, seventh nerve, and trigeminal nerve, and right side cerebellum without any raised ICP signs, without any hydrocephalus.
Okay,
With no neurological, no motor weakness.
With this cluster of symptomatology, what will be the most probable pathology involved?
Anatomical localization.
Anatomical localization is in the cerebellopontine region, cerebellopontine region.
Okay. What is the most probable pathology?
Most probable pathology is vestibular schwannoma.
What are the other differential? I got to offer a differential diagnosis. You want to tell like that. Okay. What are the other differential diagnoses for such a lesion? What are the other lesions can be present?
Other differential diagnoses are cerebellopontine angle meningioma. Can we see cerebellopontine angle epidermoid?
Are you able to differentiate all these lesions in history itself? Are you able to salient points for each two or three thing? How will you differentiate? Meningioma history will be like that. In epidermoid history will be like that. Are you able to tell that thing?
Yes, sir. Yes, sir.
Tell
In
one or 2 points in favor of.
Yes, sir. In epidermoid patient will have irritative type of symptoms. Usually will have present like trigeminal neuralgia, sir, in epidermoid.
Okay, what about meningiomas?
In meningioma, hearing will not be involved as an initial symptom.
You most probably think of these cases as it's a case of CP angle schwannoma. Huh?
Yes.
Or something else.
CP angle vestibular schwannoma.
Okay. Then and now proceed to the
one or two questions, Sri.
Okay.
What is the triad of symptomatology to say it is a CP angle syndrome? Is it present in this patient or not?
Yes, sir.
Yes.
Tinnitus, vertigo.
Tinnitus?
Vertigo, sir.
Vertigo or?
Tinnitus, hearing loss and unsteadiness.
Disequilibrium. Tinnitus, hearing loss and disequilibrium. This symptomatology triad indicates that it is a CP angle syndrome. And you mentioned that taste is affected. So what is the sensory component of the seventh cranial nerve?
Cauda tympani.
Cauda tympani. Okay. So what you have said is a special sensation. Is there a cutaneous sensory distribution for this?
Yes, sir. Trigeminal.
Not trigeminal. We are talking only about this seventh cranial.
Yes,
you said this special
in the region of sensory is in the region of external auditory meatus and posterior auricular region is supplied by facial nerve.
No, posterior auricular region, or be very clear.
Map side region.
It is the posterior portion of the external auditory canal, posterior aspect. That is called? Who described it and how? What is the sign, name of the sign? Okay. Since taste is involved, The possibility of a sensory involvement in this patient with the seventh nerve is also there. Did you ask that question? Did you ask the patient whether there is any sensory disturbance in the external auditory canal, the posterior aspect?
No.
You should have asked. And it should have come in the negative history because you specifically mentioned that the taste sensation taste is involved. Okay. So there is a high possibility that the Hitzelberger sign can also be present. Okay. Fine. Proceed.
To the clinical examination. Before the general examination.
General physical examination. Patient is moderately built and nourished. There's no signs of pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. No neurocutaneous markers. Radial pulse is 80 per minute, regular in rhythm and in good volume. Blood pressure is 110 by 70 millimeter of mercury, measured in right arm, lying down position. Respiratory rate is 15 per minute.
Okay, stop that. What are the neurocutaneous markers?
Capillate spot, sir.
What is capillate spot? When it is significant. In children, what is significant? In adult, what is significant? In children,
if the lesion is more than 5 mm, it is significant, sir. In post-pubertal age, more than 15.
Is it a size or number?
Number and size. Sir.
What are they?
More than 6 spots. More than 6 capillary spots in pre-pubertal age, more than 5 mm, and in post-pubertal age, more than 15 mm.
Okay, what is the next neurocutaneous marker? One is capillary spot. What is the meaning of capillary? Why they call it capillary? Okay. Go to the next neurocutaneous marker.
Axillary prickling, sir.
What is axillary prickling? In which cases it is common? Okay, next, what is the other neurocutaneous marker?
Multiple neurofibromas.
Okay.
Then
this neurocutaneous marker is important in the CP angle case. Why?
Yes.
Why?
It is associated with neurofibromatosis. NF2 bilateral vestibular schwannoma is associated. Vestibular schwannoma is common in NF2 patients.
So you have to give more importance to the neurocutaneous marker in case of CP angle. Okay. You must know all the neurocutaneous markers. What are the other neurocutaneous markers? You said only 3: axillary prickling, yes, neurofibromatosis, and this capillary spots. What are the other neurocutaneous markers?
Sphenoid wing dysplasia, cortical bone thick.
You didn't mention about the regular things. You are something you tell something extraordinary always. You have to tell a routine common thing. It is a common clinical presentation. It is a long case ordinary presentation. You have to present a simple thing, no? So you have to tell the simple thing first.
Athlete macules.
We expect, yeah, like that. We are expecting. We are expecting a simple things from you. We are not expecting something extraordinary from you. Okay. What are the other things? Athlete macules, where will be present? In which case it will be present? Okay, you must study all this. All the pages you study about the in detail about the neurocutaneous markers. At any point of time, examiner may stop you at the neurocutaneous marker itself. It will give a bad impression about you. You have to tell these things correctly. Once you tell these things correctly, examiner will be very happy. He will not ask these questions again to you. Okay, go to the next thing, general examination.
CNS examination, sir.
Okay.
Higher mental function, patient is right-handed. Language and comprehension is normal, sir. Memory is normal. Minimental score examination, score is 30 out of 30.
Okay.
Cranial now examination, olfactory now, right side, both sides normal, sir. Optic now, visual acuity, both eyes 20 by 20, visual field normal, and color vision also normal on the both. Sir. Fundus, there is no papilla edema in both the eyes. Of 3, 4, and 6 now examination. Eyelid is normal. Pupil bilateral 3 millimeter reacting to light. Sir. Direct and indirect light reflex present. Extraocular movements are full. Sir. Nystagmus. There is a coarse high amplitude low frequency nystagmus on attempting right gaze, and fine low amplitude high frequency nystagmus on attempting.
Go to the previous slide. Go to the previous slide. In optical examination, you have to tell the fundus finding, then you tell there is no probability. It will be a more impressive.
Okay.
Okay, go to the next slide. Next slide.
Nystagmus, coarse high amplitude low frequency nystagmus on attempting right gaze, and fine low amplitude high frequency nystagmus on attempting left gaze.
What is this nystagmus?
This is Brun's nystagmus.
What are the types of nystagmus you know? What is nystagmus? What are the types of nystagmus you know?
Nystagmus is the rhythmic involuntary movement of the eyeballs. Types are horizontal and central nystagmus and peripheral nystagmus. Other types are horizontal and vertical nystagmus.
How will you classify that nystagmus? Based on which what are the components of nystagmus?
What are the components of the
Slow,
nystagmus?
slow and slow component and fast component.
How will you name the nystagmus? Based on which?
Based on the fast component, nystagmus will.
The direction of the fast component decides
Direction of the fast. Type
There
of nystagmus.
Okay, you said there is a two type. What is another type of nystagmus? Vertical, horizontal, another one is
Rotatory.
What is the type of nystagmus here?
Here is a horizontal nystagmus, sir. Patient is having.
What is it signifies?
Signifies the lesion is in the cerebellum, sir.
You said it is a.
Sir? Lesion is in the cerebellum.
You know there is a way of marking nystagmus. Do you know that? How will you mark the nystagmus? There is a way of marking.
Mask.
Mark, not mask.
Mask.
Mark. How will you write the nystagmus? You are able to write the nystagmus in a paper, no? It is given in Shetty Rangachari. It's given in the textbook of Shetty Rangachari. There are how will you mark? How will you write the nystagmus in the case sheets? Okay, don't read that. It is in the Shetty Rangachari. Okay. Proceed to next thing. Next session. Next.
See,
Right
how do
now?
you base the severity of the nystagmus? Grade. Okay, go on, read.
Next.
Trigeminal now, motor component is normal, sir, bilateral. Sensory component, right side V1, V2, V3 distribution, touch pain and temperature sensation are decreased. Sir. On the left side, it is normal. Corneal reflex, right side direct is absent. Sir. Left side direct is present. Sir. On the right side, attempting indirect. On attempting on right side, left eye closure is also absent. So indirect is absent on the right side. Sir. On attempting indirect on the left side, there is a delay in the closure of the right eyelid. Eyelid is present on the left side. Right side, left side indirect is sluggish.
Closure possible,
Sir?
Is it they are able to close it or not?
Sir,
Right side,
patient
no,
is able to
eye closure.
eye closure with effort, minimal effort is there, sir. But
What
there is a slowness. Able to close, sir, but when compared to the right side, left side, it is delayed, sir.
There is a facial weakness, you mean?
Yes, sir.
Facial, huh?
Yes, sir. Weakness on facial weakness on the right side.
Okay, before going to that, how will you test the motor component of trigeminal?
Ask the patient to cleanse the teeth, sir. We have to check for the contour of masseter muscles, sir. Then using spatula, we can check, sir. We, ask the patient to cleanse the spatula and cleanse the teeth. Based on the impression on the spatula, we can compare
Super.
right and left side.
Very good.
This one thing, which area will you palpate? Where will you palpate the masseter muscle?
Feel the contraction.
Before asking the patient to clench the teeth.
On the over the masseter region.
Or the masseter
Anterior part
posterior?
Anterior part of the masseter we have to.
So what will you look for? Anterior part of masseter, you put your
check
finger.
For contraction.
Contraction, what will happen?
Contraction.
How much your finger is pushed anteriorly when it is touched, whether it is symmetrical or less on one side.
You said there is no jaw deviation.
Yes, sir.
Huh? You didn't mention about that.
In history, okay. Examination.
You wrote in examination, you have to tell, no?
Yes, sir. Okay.
How will you see the jaw deviation? In examination of trigeminal
ask the patient. Yes, sir. Ask the patient to open the mouth, sir.
How will you identify jaw deviation?
We have to insert the fingers while opening the mouth, sir. If a patient is having difficulty in opening the mouth, not able to insert
finger, what are you telling? I am asking you to identify the jaw deviation. How will you identify the jaw deviation? You tell me that you have to
suppose the right side motor component of the fifth cranial nerve is involved. Okay. Which side will be the deviation?
Deviation will be towards the right side, sir.
Towards the right side.
Okay. How will you identify that?
Say there is a deviation. You have to mark the midline, right? How will you do it? That's what
Sir gives the clue. Sir gave the clue. Sir gave. Okay.
Jaw deviation what will be the midline reference?
What are all the tools? Nose, sir. Not nose. Nose keel enna irukku. What is that below the nose? Incisor teeth irukku.
நடுவுல என்ன இருக்கு?
Incisor.
Filter ஒன்னு இருக்கு. அதுக்கு அப்புறம் incisor teeth இருக்கு. ரெண்டு தான்
mark the midline of the upper lip, lower lip.
அதுக்கு deviation இருக்கா? ஓகேவா? அதுக்கு அப்புறம் இல்லனா அதுக்கு ரூலர் யூஸ் பண்ணனும்.
ஓகே.
ஓகேவா? ஃபிங்கர் கொடுத்தனா கடிச்சிடுவான். அதுக்கு அப்புறம்
So why is it deviating towards the same side?
Due to the contraction of the opposite side pterygoid contraction leads to.
What are the muscles of mastication?
Masseter temporalis, medial and lateral pterygoid.
What are the depressor? What are the elevator? All the muscles are. One is.
Forgot.
See, you should understand mastication. Why sir is asking is mastication involves opening of jaw,
closing
of jaw, and the lateral movement of the jaw also. You understand? Yes. There is a protrusion and retraction of the jaw also. So there are 6 possible movements. And what are the muscles that do those make those movements possible? That's our கேக்குறார்.
படிக்கிறியா?
Will you test the temporalis muscle? Sorry, okay. Now you have told 4 muscles. Okay. What are the other 4 muscles supplied by the fifth cranial nerve? You told masseter, temporalis, medial, lateral pterygoids.
Yes, sir. Anterior belly of digastric, sir.
Hmm.
Milo.
சரி போய் படி. Okay.
Next proceed to next cranial patient. You said
Sensory
there is
component.
you said there is a difficulty in closure of
Yes, sir. Right eye closure is difficulty.
Bilateral facial now involvement with bilateral sensory with the intact trigeminal now. How will you identify that? Bilateral facial nerve palsy.
Yes, sir.
How will you identify them? Sensation is present or not in trigeminal. How will you test the trigeminal nerve? In case of bilateral facial nerve palsy.
You can have a sensory loss even in a high cervical cord lesion, right?
Yes, sir. Onion peel type of sensory loss in trigeminal.
Why onion peel? Why there is onion?
Due to involvement of spinal nucleus of trigeminal nerve.
Topographical representation of trigeminal nerve. Okay.
So where is it usually starts the sensory loss in case of an onion peel? And where will you start examining?
Around the in the perioral region.
Oral and the nasal region usually.
Nasal region. It will start.
And the back of the face is involved the loss. So you should start there. So how will you identify whether the patient is malingering with the facial sensation of the face? What are the lines? Okay, go on study. Patients may present with facial sensory loss, but it will be
examination of 8th cranial nerve.
Examination of 8th cranial nerve. Rinne's test here on the right side, bone conduction is better than air conduction. On the left side, air conduction is better. Air conduction is better than bone conduction on the left side, sir. Vibus is lateralized to the left side, sir. Absolute bone conduction test is reduced on the right side and it is normal on the left side. And vestibular testing, Fukuda stepping test and star walking test are not done, sir, since the patient was not able to stand without support.
Next.
Rinne's, come again.
Rinne's right side mistakenly right side also air conduction is better than bone conduction.
Right side also air conduction is better than bone conduction. That is a mistake, right?
Yes.
Bone conduction, what does that mean?
Sir, air conduction is better than bone conduction is it will be usually present in the normal ear or patient presenting with the sensory neural hearing loss.
See, let us say the V-bus is lateralized to the left side.
Left side.
Okay. Patient has no air conduction at all. Okay. But says bone conduction, able to perceive bone conduction.
Okay.
Is it possible?
Yes, sir. Patient with the profound hearing loss able to hear the bone conduction through the osteoconduction from the opposite side.
When this is tested on the other side. So what is it called?
False negative Rinne.
Okay, proceed.
9, 10, 11.
Glossopharyngeal, vagus, and cranial accessory. Motor normal. Sensation is also normal. Taste sensation in the posterior 1/3 of tongue is normal. Salivation is normal. Uvula is in the central position. There is no flattening of palate. Gag reflex is normal on both the sides. Spinal accessory, patient able to shrug the shoulder and able to turn head on the both sides. Hypoglossal nerve, bulk of the tongue is normal, sir. There was no furrows, tremors, or deviation.
In history, you mentioned about the loss of taste sensation.
Yes, sir.
What is your examination finding about taste?
Taste in the anterior two-third of tongue and tip is absent on the right side, sir. For sweet, salt, and sour, sir.
Sweet, salt, and sour. Where will you use the test for the taste sensation? You have mentioned it is absent in the tip.
Tip for sweet, sir.
Where is the taste buds most concentrated? Is it at the tip or somewhere else?
At the junction of anterior two-third and posterior one-third, it will be junction of anterior one-third and two-third and posterior two-third.
In the middle third.
Yes.
So you should test there only. Did you test it there?
Yes, sir. Yes.
You tested there only.
Yes.
So how did the patient tell you?
Sir, first, before testing itself, we have to instruct the patient, sir, not to take the tongue inside while examination, or not to talk while for the results. Ask them to symbolize the results, sir. If they are able to feel the taste, they should raise the hand, or they should write. If they are able to write, they can write and tell. And
how will patient write? His eyes is closed, right? Eyes will be closed, right? Yes. Okay, you checked at the anterior one-third, middle third junction.
Yes.
Right. Okay. So what is the fifth type of test you have to study? Fine.
Yes. Fine motor examination, sir. Bulk is normal on on all four limbs, sir. Tone, bilateral upper limb and lower limb normal. Neck power, range of movements are normal on the neck. Both upper limb, bilateral upper limb and lower limb power is 5/5. Reflexes, all deep tendon reflexes are biceps, supinator, triceps, knee jerk, and ankle jerk are 2+. Superficial reflex, abdominal reflex, and plantar reflex. Abdominal reflex present, sir. Plantar reflex, bilateral flexor. Sensory system, fine touch, proprioception, and vibration sense normal. Pain and temperature normal, sir. Rhombus test not done, sir.
Vibration sense is normal throughout the body? You said patient has fifth cranial nerve involvement.
Yes, except on the right half of the face, normal in other parts of the body.
Except in the right half of the face? Where did you check?
On the malar prominence. And over chin midline.
Over the midline.
Over the mass face level, over the malar prominence.
See, be very clear. When you are examining trigeminal nerve, facial sensation, there are two bones which are single bones. One is mandible and the other one is frontal bone. Mandible, they are single bone. There won't be any difference in vibration between the right and the left side. If you say there is a difference, then you have not done it. That is one way to identify whether the patient is malingering or not. If there is a difference in the vibration sensation between the left and right, when you examine the mandible or in the frontal bone, then the patient is actually lying. And then you are also saying the same thing. So either you didn't do it. Huh?
Malar, I checked, sir. Over the mandible and all.
Okay. Proceed to next thing.
Cerebellar function, Dysdiadochokinesia is present on the right side. Patient is having difficulty in alternate movements on the right hand while doing faster. Rebound phenomena is present on the right side. There is no intentional tremor. Muscle tone, there is no hypotonia or no pendular knee gesture. Speech is normal. Finger nose finger test is impaired on the right side. Fast pointing is present on the right side. Heel knee shin test is impaired on doing with right foot. Tapping in a circle is normal. Drawing a circle in air by feet is impaired on the right side. Tandem walking not able to perform. Nystagmus is a coarse high amplitude low frequency nystagmus on attempting right gaze and fine low amplitude high frequency nystagmus on attempting the left gaze. Posture sitting is normal, sir. No truncal ataxia, no titubation. And standing, there is a tendency to fall towards the right side, sir. Pronator drift, the patient right hand slowly deviates laterally.
Pronator drift motor support. Cerebellar system. Pronator drift on the guest.
Mild deviation is laterally.
See, is the deviation because of a vestibular involvement or a cerebellar involvement, or is it because of a motor component? You have to differentiate and say now. Since you have committed drift, now you have to say. You have mentioned it under cerebellar dysfunction, right?
Yes, sir.
So how will it be in case of motor weakness? How will it be in case of a vestibular problem?
Motor, there will be down drift in the case of motor weakness. When patient is having weakness, the hands will drift downwards. In case of parietal lesions, there will be updrift while doing pronator drift. In cerebellar lesions, it will be deviating to laterally due to vestibular.
Sorry. Next.
Gait not able to assess. Cranium and spine normal. Respiratory system, bilateral air entry equal, there is no added sound, sir. Cardiovascular system, first and second heart on the third, no murmur. Abdomen soft, no tenderness or no palpable mass or organomegaly.
Say, before going to diagnosis, what is the clinical examination? Provide extra information from the history.
Extra information is in addition to history, patient is having a right-sided facial nerve palsy, grade 2 facial palsy also.
The observation.
You mean to say motor component also involved?
Motor component.
Because even in history, you have mentioned that test is affected.
Affected.
Seventh was already involved. Additional
motor component
I got is, yes, motor component of the seventh cranial nerve is also involved.
With this provisional diagnosis in your mind, what are the investigations you will do?
First, I will do audiometry, sir, for hearing assessment. Then I will go for imaging, sir.
In audiometry, what is your expectation?
In audiometry, my expectation is right side sensory neural hearing.
When will you try to do a hearing preservation?
When there is a serviceable hearing, we can try to do hearing preservation.
What is serviceable
hearing? Loss is acute on average if it is less than 50 decibels, and speech discrimination score between 50 to 70 is serviceable.
Why this is important? You have to assess the audiometry in each and every cases of CP angle.
Yes,
why
sir.
it is important?
Medico-legally, it is important, sir. First, and to decide on the approach.
To decide on the approach, you have to know the auditory status of the patient prior to surgery. Okay. So each and every case of CP angle, you have to do a audiometry,
Audiometry.
compulsory one. Okay. Next, what is the investigation you do? What are other investigation you do?
Imaging. First, I will do CT brains. Then
Why don't you go for MRI directly?
Sir, CT is immediately available, sir. Yeah, in emergency setup.
What is the emergency here, man? This patient is
No rise the ICP.
for a past is suffering the illness for past so many months. What is the emergency here? What CT gives?
Unconscious or raised ICP, altered sensorium. These are the situations you go for a
CT scan immediately. What for in a elective case? What is the use for CT in this case? What is the necessity for CT?
You do CT or not?
Yes, sir. I will do CT, sir.
Why you do CT? If you do CT, what are the things you as a neurosurgeon you ask?
I will see the high reading of the jugular bulb.
You said CT brain, right? You should ask for a CT of the
temporal bone.
Temporal bone.
So on the jugular bulb.
What are the things you will see in the CT temporal?
Mastoid pneumatization.
Why you have to see the mastoid pneumatization? ஏன்பா பார்க்கணும் mastoid pneumatization? சரி, ட்ரில் அடிச்சேன்னா mastoid pneumatization ஜாஸ்தியா இருந்ததுன்னா என்ன ஆகும்? Okay, first you have to see pneumatization. First you self the critical clinical. What are the things you have to see? First is mastoid pneumatization. Second is high reading of jugular bulb.
High reading jugular bulb.
Third one is
widening, internal acoustic meatus widening can be seen.
அதான் அது எதுக்கு? What are the other structures you will see? You have to see the CT temporal bone. You have to see the semicircular canals and the carotid relationship. For that only you have to see the thing. Okay.
Okay.
Then you will go for a MRI. CT முடிச்சிட்டியா? That's all for CT. MRI. So previous I want to forget to ask about you. What is the extent of according to your presentation? What is the size of the probable size of the tumor? I forgot to ask this question. You do a history. You did a clinical examination. After that, what is your thinking about the probable size of the tumor?
Probably up to 3 centimeters.
Is there any relationship there? Tumor size and the symptomatology. What are the relationship?
If the tumor is less than.
If it is more than 3.5, you will have motor symptoms and other things. Okay. So the tumor is most probably more than 3.5. Why the size is important? Size of the tumor is important. Is it or not?
Yes, sir.
What is okay? What is the importance?
Sir,
for the treatment plan, you must have the for if the tumor is less than 3 centimeter, 2.5 centimeter, you can go for SRs directly for this type of cases. So size is very important. By clinical judgment, you have to tell by the clinical symptomatology alone, you are able to judge the size of the tumor. Okay. Now go for MRI. What is the MRI?
One minute. What is the extent of this lesion, the CP angle? How will you divide the CP cerebellopontine angle system?
Into
how many
3
triangles are there? Huh?
Superior and inferior.
Some books say superior, central, inferior. Some say superior, middle, and inferior. Some books divide the middle into or central into again into two
Again,
triangles. So what is the extent of this particular lesion?
By history and a clinical examination alone, you are able to tell.
Yes.
Sir, here there is no lower cranial nerve involvement, sir. Only 7th and 8th and 5th nerve is involved, sir.
So
lesion,
basically, the central and the superior triangle is
only involved.
Okay. MRI பார்த்தியா?
Yes, sir.
What is the MRI?
Sir, this is T2 axial section, sir.
சரி இதுக்கு முன்னாடி இப்ப before going to that there are certain characteristics. This is CT differential diagnosis for meningioma and CP angle tumor. We have the CT that for that case. CT for this patient.
Yes, sir.
Where is that? Did you put contrast for that?
No, sir.
So you describe the CT findings. Tell me the CT findings. What are the findings?
There is an heterodense lesion in the right cerebellar Functions angle, sir. With displacement of the fourth ventricle. Sir.
Not able to see that, man. I'm not. Is there any displacement of fourth ventricle? Is there any hydrocephalus?
No hydrocephalus, sir.
Where is the displacement?
Sir?
Are you able to zoom the thing? Zoom the fourth ventricle. Zoom the posterior fossa. Zoom the.
Sir, there's a heterodense lesion in the cerebellar Functions angle, sir.
Okay. What is your differential diagnosis based on this CT finding alone? What is your differential diagnosis for the based on CT alone? You are able to tell something about that?
Sir, based on the CT finding, most probably vestibular schwannoma, sir.
See, the fourth ventricle is deformed and the temporal horn is seen on the right side, isn't it?
Yes,
usually it is not seen on the left side also, it is a bit more prominent.
Go to MRI, I am not able to.
And why do you, how do you decide it is an extraaxial or an intraaxial lesion?
It is probably an extraaxial lesion, sir. That
why?
An extraaxial lesion, that can be a CSF cleft. Probably the typo density can be a CSF cleft between the lesion and the.
What do you see in the first image of the second row? What happens to the ipsilateral prepontine system if it is an extraaxial lesion?
It's the widening of prepontine system will be
widening of the, is it seen or not? Is it present or not? Yes, no. It is present in the first image, in the second row, isn't it?
Yes, sir. It is present on the right side. Mild enlargement of the field.
Ipsilateral system is wide and the prepontine system. That is what you should say. Okay.
Then, if there is any temporal bone window you are showing now?
Yes, sir.
Are you able to zoom the temporal bone now? Then only you are able to see the trumpet. This is a trumpeting sign there. In the bilateral foramen, acoustic foramen, you have to zoom that. Okay, next time you will present like that only. Is there any widening of internal acoustic meatus in this case?
On the right side, internal acoustic meatus widening is there.
Is it there? We are not able to see it clearly. You have to show it as a presenter. You have to show that very clearly. Okay. Is there any widening? Is there?
Yes, sir.
You have to see all the things we already suggested. You have to see that in temporal bone. You have to tell about the As that pneumatization, you have to tell about the widening of internal acoustic meatus. You have to tell about the jugular curve like that. You have to tell the indicity bone window. Okay. As a
Okay.
presenter, you have to tell all these things. Is there anything here? Everything is normal or abnormal here?
Here, widening of internal acoustic meatus is present on the right side, sir.
Okay. Nothing else you can see.
There is no hyperostosis on the right side of fetus part.
Okay, proceed to MRI.
MRI, this is the T2 axial section MRI brain, showing heterointense lesion in the cerebellopontine angle, sir. With the lesion arising, enlarging outside from internal acoustic meatus on the right side.
What is that zone is called?
Ice cream cone appearance. Sir.
That is ice cream cone appearance. What's the zone, pathological zone? It is, what is the name of the pathological zone from the tumor arises?
Redlich zone, sir. Hello? Sir, Redlich zone, sir. Redlich zone, sir.
Sure, okay. What are the differential diagnosis for this case?
For this case, my first differential diagnosis is vestibular schwannoma, sir.
Next, how will you differentiate between the CP angle meningioma and the CP angle schwannoma? These are the routine questions.
Yes,
each and every exams you have to face these questions. You have to tell me the salient 5 points for CP angle meningioma, CP angle schwannoma. Salient 5 points.
Okay. Here the patient is here in MRI. There is a classical lesion arising from the internal acoustic meatus and expanding after coming out of it.
Ice cone appearance.
Showing ice cone appearance. Then the angle between the internal artery canal and the lesion is acute. Sir.
In which case acute? Which case obtuse?
In vestibular schwannoma, it will be acute. Sir. In meningioma, it will be obtuse. Sir.
Okay. What are the other findings? There are 5 to 10 differential points is given in Satirangachari. Okay. You are telling only one now. What are the other 5? Other 4 or 5? There are a lot
here
of
the lesion. Here the lesion is heterodense.
I'm not asking about this case. I'm asking about the differentiation by imaging in CP angle meningioma and CP angle schwannoma. I'm not
CP
asking
angle meningioma. There will be broad-based attachment.
Broad-based attachment. Here,
there is no broad-based attachment. Ice cone
type of appearance will be there. Obtuse angle, acute angle. Second point. Next.
On contrast enhancement, there will be homogeneous contrast. Homogeneous contrast enhancement will be there in meningioma.
Dural tail sign இருக்கும்.
Dural tail.
அதுக்கப்புறம்
will there be any bony changes?
Yes, sir. Hyperostosis will be there in the meningioma.
சரி, அதெல்லாம் salient points given in Satirangachari, you have to read that. You have to tell clearly in each exam. Okay.
Okay.
Next, what is the size of probable size of the tumor? Why the size of the tumor is important? I already told you. By that only you have to make a management decision.
Okay.
And this sensorineural hearing loss, the hearing loss, serviceable hearing or non-serviceable hearing, that is also important. In case of serviceable hearing, non-serviceable hearing, this region is less than 3.5. What will be approached? How will you? For the management issue, you have to know about the size. You have to tell MRI. You have to tell first the size, shape, situation, systems, hydrocephalus, everything you have to tell.
Yes,
tell me all these things very fastly.
Sir, the T2 axial section of MRI brain showing a heterodense lesion in right CP angle region. with the widening of the right side prepontine cistern, CP angle cistern, and the lesion is heterodense and it is round to oval in shape, globular in shape. The extent is from internal aquatic meatus to extending into the right cerebellum and mild compression over the brain stem.
Anterior, what are the other structures you go to see? Anteriorly, what are the structures you go to see? Which vessel goes anteriorly?
Sir, anterior inferior cerebellar.
அதெல்லாம் ரைட். ஆன்டீரியர் அதுக்கு முன்னாடி மேஜர் வாஸ்குலர் ஸ்ட்ரக்சர் பிரசன்ட் ஆன்டீரியர். பெசிலர் வரைக்கும் போயிருக்கா டியூமர் பெசிலர் இன்வால்வ் ஆயிருக்கா இல்லையா? Go to see what are the vascular structures involved, what are all the brain cell structures involved. These things you have to see in the imaging. Okay, you have to see the hydrocephalus also.
Yes.
Based on the clinical and the imaging findings, how will you proceed this case?
I will proceed with surgery, sir. Right side
Surgery. Patient will ask the tumor is small in size. What are the other options you are having? They may ask.
Other options are.
What are the options here for this patient? This case. What is the size of the tumor? What is the serviceable hearing loss?
Here,
what is the percentage of hearing loss?
Here, the patient is having a profound hearing loss and non-serviceable hearing loss on the right ear.
Okay, okay. Size of the lesion?
Size of the lesion is 3 centimeters.
Okay. What is your management option for this case?
My management option is right side retromastoid retrosigmoid craniectomy and excision.
அதான் அந்த பக்கம் இது போயிடுச்சுல ஒரு டோட்டல் ஹியரிங் லாஸ் இருக்குல்ல அப்போ which is the best approach? What are the approaches? What are the approaches available for CPNG?
Transcochlear approach. Then
I am asking retromastoid approach. Transcochlear approach.
Then middle temporal fossa approach.
Middle temporal. Which approach you choose in this case?
For this
which
case,
is ideal? Which is ideal? Which is
ideal?
Which you will choose?
In our institution, we are doing retromastoid retrosigmoid.
Why?
We are more familiar and for
routinely we are doing that. We are familiar.
Cisternal component is more in this patient.
Total hearing loss இருந்ததுன்னா transcochlear approach தான் best approach. Size கம்மியா இருந்தது.
Okay.
What are all the different? What are all the advantages and disadvantages between the two approaches? Transcochlear approach.
Transcochlear, less invasive approach.
Less invasive. Transcochlear, அதோட advantages என்ன? Retrocochlear ஓட advantages. Retromastoid ஓட advantages.
Transcochlear we cannot preserve the hearing.
Retromastoid தேவையில்ல, இதுலதான் serviceable hearing loss இல்ல டோட்டலா serviceable hearing loss பேச்சுல நீ என்னத்தை preserve பண்ண போற? You not going to preserve. Next, what are the precautions you will take while opening the dural opening? What are the things?
Cerebellum can be bulging. So
cerebellum bulging illa. There are a lot of sinuses in the dural leaflet. Enna sinuses in the dural leaflet la?
Transverse and
adu lateral side la irukra sinus. Yes. Lateral irukra sinus enna sinus?
Transverse and
sigmoid sinus. While opening the near the foramen magnum, there are circular sinuses will be there. You have to be very careful in opening that sinuses. You have to put two artery forceps here, and you have to open the oil very And otherwise, this neural bleeding will be there. Profuse neural bleeding will be there. After that opening, what will you do?
How to
Cerebellum is bulging. Now what will you do?
cisterna magna should be opened, sir, to let out the CSF slowly to prevent the cerebellum bulging, sir, to decrease the pressure. Then cerebellum can be retracted supromedially to visualize the tumor, sir.
Tumor, there are a lot of layers in the tumor. I'm going to finish very fast. There are a lot of layers. Suresh sir, the sir will tell there are a lot of layers in the arachnoid cells. You have to be always within the arachnoid to do surgery. Okay. Once you reach the arachnoid is your savior. Once you reach the arachnoid, you will land up in trouble. Or stay with the arachnoid, you will not land up in trouble. Okay. So to the tumor, what are the methods you will remove the tumor?
Tumor debulking can be done, sir.
What are the tools you use?
Sir, QSA can be used for
debulking. Ablators, you can use lot of tools to debug the tumor.
Yes, sir.
Facial nerve preservation, what are the monitoring you use?
Facial nerve can be directly monitored using facial nerve electrodes.
Neuro monitoring use பண்ணுவியா அந்த கேஸ்க்கு?
Yes, sir.
Neuro monitoring என்னென்ன monitors?
Direct facial nerve electrode monitoring can be done, sir.
அதுக்கப்புறம் என்ன
Then facial nerve motor evoke potential can be monitored, sir.
அதுக்கப்புறம் என்ன பார்ப்பா? முக்கியமா காதுக்குள்ள என்ன வச்சு பாப்பா?
Cochlear nerve monitoring, brainstem monitoring.
Brainstem monitoring evoke potential.
Potential can be. Yes, sir.
I hope to see that.
Yes, sir.
This monitoring, you have to use that. You have to use the facial monitoring device to identify the facial nerve, so the facial. Post-operative, how closure will be done?
Sir, should do layered closure, sir. First, dura. Then, sir, if we are doing craniotomy, we can replace it.
What are the post-operative complications you expect?
CSF leak can be there, sir. Immediate. Facial nerve injury. Facial nerve injury can be there.
Intraoperative. Post-operative.
See, you have finished the surgery. Skin is closed. Patient is not waking up.
Yes, sir.
நீ சொல்ற காம்ப்ளிகேஷன்லாம் delayed. Patient extubate பண்ண அப்புறம் நடக்கிற விஷயங்கள். Now patient is not waking up.
Can be.
What are the possibilities?
Can be due to hemorrhage.
Can be a bleed.
Bleed. Can be due to injury to the brainstem. To traction.
Injury.
Traction la பண்ணேனா நியூரோசர்ஜனாவே இருக்க கூடாது.
What are the other problems? Can be an acute hydrocephalus.
Yes, sir.
Brainstem injury traction illama brainstem varalama? Involvement.
Yes, sir.
Patient
Yes,
not waking up. Oh, why? எப்படி வரலாம்? You are mainly operating
vessel injury.
What are the complications? Acute complications. அப்புறம் வந்து chronic late complications. You have to read all these things.
What vessel?
Pike. Posterior inferior cerebellar artery. Or anterior inferior cerebellar artery.
Involvement of so how will you find out clinically?
In patients,
you have a torch in your hand. இல்ல டார்ச் இல்லாம கூட பார்க்கலாமா? What intramedullary
13 point.
brainstem sign will,
Intramedullary
brainstem
can
sign
be
will,
the
you should
vertical
look for the presence of Horner's syndrome.
honor.
Pupils பார்க்கணும். Then you will, can say whether it is ICA involvement is present or not.